any introduction. She is one of our very well-known clinical...
Madam Wasim has joined.
Yeah, well-known clinical geneticist, and we would like to hear more about when to do timely genetic tests. And with that, I'd also like to hand over to our moderator for today, Dr. Wasim Kazi. Wasim, would you like to take over?
Yeah, ma'am. Thank you, ma'am. Sorry for the delay.
Can I
Yeah.
just interrupt,
Should we,
ma'am?
yeah.
Sorry, the
Should we
topic
start
that
with,
was,
yeah.
I'm sorry.
Shruti,
The
ma'am, you are
topic
ready?
that was given was impact of timely genetic diagnosis. Suddenly, I'm having peptic ulcers, madam. The topic was different. I'm just joking. So it was impact of timely genetic diagnosis.
Okay.
Would it be okay? I think there is some miscommunication.
Shruti, whatever you say will be lots of knowledge for us. So, a rose by any other name is just as beautiful.
Are. Thank you, ma'am. No, I just thought that this is not some miscommunication. So I had suggested to Jayashree madam that we always have been talking about when to when to think, when to suspect, how to suspect. I thought the why aspect of it, why should we diagnose it? What is the impact of a timely genetic diagnosis? After Dr. Wasim has done the talking, I will start with that talk, ma'am. So yeah, I'm sorry,
Yeah.
I just interrupted the flow. Yeah.
No. Shruti, ma'am, you can carry on. No issues. Just wanted to give a brief introduction, but some people don't require an introduction, so you're one of them. So I think just go ahead. We'll start with the session.
Not at all. Okay, fine, great. I'm just opening the talk and then I'll share the screen, Dr. Wasim.
Yeah.
1 minute. Yeah.
And I think we also have Dr. Smita with us, who's our observer. Maybe she can't hear us. Dr. Smita is there.
Can I start, ma'am?
Yeah, please.
Okay. So we will be celebrating World Rare. Is this visible, the PowerPoint?
Yes, ma'am. And it's full screen also. Please go ahead.
So वो कबीर का एक दोहा है. I'll start in Hindi, which says, चलती चक्की देखकर दिया कबीरा रोए, दो पाटन के बीच में साबुत बचा न कोई. Which means that the poet Kabir, he started crying when he saw the two moving off the chakki that is used to make flour, comparing it with the cycle of life and saying that no one has really survived this. At the end of it, we are all mere mortals. And I think I correlate this branch of genetics closely to, human life and its essence, because right from the womb till the tomb, there is now an understanding of the aspect and the impact of genetic diagnosis in individuals having these diseases. 29th February comes once in 4 years, which is why 29th February is celebrated as World Rare Disease Day. There used to be Nadi Shastra in India centuries back, where the Ved used to just, feel the pulse of the patient and say ki tumko ye bimari hai, take this medicine and you'll be okay. And I feel an analog of that is today genetic medicine, whereby just taking a buccal swab or 2 ml of DNA, the valid indications, we can kind of detect them in time. So the important thing over here is we have always learned and heard that when you listen to hoofbeats, think of horses, not zebras. But I always say that when you listen to hoofbeats, think of horses, but also keep your eyes open for stripes, because a zebra will come mimicked like a horse in your OPD, So spotting the rare disorders is very important. A small prelude to the burden of genetic diseases before we actually start on the impact of a timely diagnosis. We are aware by now that there are more than 7,000 rare diseases globally, and 80% of these are genetic in origin. They say if all the people living with rare disorders were to live in one continent, that would be the third largest continent in the world. And India is no exception. In fact, India shares 1/4 of the global burden of rare disorders. I mean, really, with a population of 140 crore, what can really be rare? And it is now estimated that 1 in 10 individuals will live with a rare disease at some point in their lives. Why is it so important being a pediatrician, being aware of these disorders, because 50% of these rare disorders will affect children. And unfortunately, 1/3 of these will die before their first birthday. Um, Rare is not rare, rare is in fact many. And we realize that because of their overlapping symptoms, lack of awareness, these patients go through a long diagnostic odyssey. As per a study in US, an average time taken by them is nearly 7 years. And even after that, just 41% of them get a confirmed diagnosis. India is actually a boiling pot for genetic disorders. The different types of ethnicities, the universality of marriage, consanguinity, endogamy, that's marrying within the same communities. These are all factors which gives rise to practically every genetic disease that's been documented has been reported in our country. And the authors of this paper, which was a landmark paper, concluded that the burden of genetic disorders in India is unequal to anywhere else in the world. Why and how do NICUs and PICUs become so important? We realized that as per a study published in Genetics Medicine, these genetic disorders, at least in the Western world, could contribute to nearly 3/4 of neonatal and infant deaths. And targeting this period of the infant period, thinking of the red signs early, could actually be a high yield period. And this is not an exception. Just 15 days back in Times of India, which there was an article about pediatric surgeons and JJ Hospital and them not having adequate number of experts, there was a figure which said how congenital anomalies had risen from the 7th position to the 5th position in terms of the contribution of under 5 mortality rates. These are Indian statistics. And you can imagine that this is going to be an understatement given the fact that we haven't really even diagnosed all the cases. So obviously, even without complete diagnosis, we are understanding that congenital anomalies are responsible for the 5th commonest cause of mortality in under 5 children. Needless to say that these anomalies, if not detected, not corrected, not just add to the psychological burden, but also to the economic burden of the country. So the onus lies on us to pick up these disorders in time. And that is going to be the next 30 minutes of my talk. That, okay, fine, we understand that rare disorders may come mimicked and they may be relatively common and we could be missing them, but why should I pick it up? I mean, kya farak padta hai? At the end of the day, there is no treatment. These are the arguments that we hear often. And what if the family doesn't want to plan another child? And is there really an impact of making a diagnosis? So I think I love this paradigm shift in the nature of how we as geneticists are discussing this why. So maybe 10 years back, the only reason why we stressed was, see, it's all about the next child, try and get an answer. But treatable genetic disorders has entered the realm of practice in such speed and with such zeal that I think we can actually have a 2-day CME on just the treatable pediatric genetic disorders. And that is the change that has happened in the last decade and a half. We are aware about these expensive drugs because they catch our eye. We're aware of this 17 crore injection, spinal muscular atrophy. You give it to the child early and the child can live a normal life. But I want to stress over here that not all genetic treatments cost 17 crores. In fact, some of them may just cost a monthly expense of 30, 40, 100 rupees, right from tablet biotins, pyridoxine. There are so many metabolic disorders. We know pyridostigmine for congenital myasthenia spectrum, inborn errors of metabolism, and a lot, the list could go on and on. I'm going to allude to the point of why timely diagnosis is important with this little case example, which I have shared on this forum around 2 years back. I would like to thank Dr. Ankit Gupta from Wokat for getting me involved in this case. This was a child who in the antenatal period had red flags in the form of polyhydramnios, decreased fetal movements, breech presentation, cesarean section, had some feeding difficulties, apnea, but well, things got okay. Child was discharged, doing well, normal milestones. Just noticed in retrospect that she had some ptosis in the evening hours. And parents were like, but milestones are perfectly fine. The story started unfolding after the first birthday when back to back in few months she kept getting recurrent apnea episodes, so severe that in one of the episodes she required prolonged CPR, which caused secondary hypoxic injury and spastic quadriparesis. By the time they involved us at 20th month, the pattern was actually suspicious of what we call as congenital myasthenia spectrums, where the neurotransmitters to put it simply, it's a neurotransmitter related neuromuscular junction defect, which can be correctable, and that can sometimes come with just isolated apnea, joint contractures, may not have delayed milestones, but this ptosis aspect has made us suspicious. So we started the child on empiric pyridostigmine, sent the genetic test. The child got extubated in a period of 24 hours, which means that we were probably on the right track. And a month later, we got the genetic report that indeed this was rhabsine-associated congenital myasthenia. But as a whole, our entire team, we were not, because this is something which should have maybe got picked up way earlier, because rhabsine associated congenital myasthenia is a treatable disease. If the child would have started this treatment before the apnea, she wouldn't have been spastic quadriparetic. And the best part is that these children outgrow the disease. The way we say for asthma, that some children will outgrow wheezing, they outgrow it and don't even require long-term medications. But वी से ना इन हिंदी, भगवान के घर पे देर है अंधेर नहीं, पर कभी कभी देर का मतलब अंधेर होता है, and delay means denial. At 21 months, if we are giving the child parents a neurologically impaired child, I think somewhere as a medical community, we all need to take up the onus of trying to pick up these red flags early in our practice, and they will never come to our OPD as congenital myasthenia. The signs would be hidden in the so-called common cough and cold or routine pediatric visits, routine vaccination visits. So this is just an example to say how it's not a desirable outcome for a treatable disease, but at the same time, these cases teach us a lot of things, how to approach these scenarios in future. It's also very interesting and intriguing that not all congenital myasthenias can be treated in the same way. So given a mutation in rhabsine, you treat with pyridostigmine. But if you have a COLQ mutation, you avoid pyridostigmine. I give an example how we dictate the antibiotics based on culture sensitivity. So that is how genomics has entered our clinical practice, that not just are disorders treatable, but even the choice of the drug, the personalization of the medicine can depend on your genomic report. This is another example where this child was a 9-year-old male child, uneventful birth, global developmental delay. He had seizures, had encephalopathy, dystonia. Really, there was no reason, but still this child was considered to be a cerebral palsy because of the dystonia, despite a normal perinatal history. The penny actually dropped at 2 years of age when an MRI was done for seizures, and it showed features suggestive of glutaric acidemia, which was actually confirmed by TMS GCMS. And this is actually a completely treatable disorder if it is picked up in time. Agreed, there are decompensations, and if the treatment is started after basal ganglia injury, we cannot salvage a lot. But again, delay diagnosis for disorders where there is treatment can cause neuromorbidity as well as premature death. These are some of the patients which are there at Purple Gene Clinic, which we have been following up. This is a child with methylmalonic acidemia. He had acute encephalopathy, global developmental delay, seizures. He is the son of a simple tailor from Mumbai region. And let me tell you, his mother doesn't even know how to write, but she's got the spirit of Rani Lakshmibai. She's like, I'm going to do everything for my child. She audio records what I say, goes back, understands that, she knows the red flags, she knows how to give the special diet. And now after 4 years, the child is going to normal school. He has some scholastic backwardness, but from the boy that we had seen him, he's really grown up. He's picked up on his growth, no further encephalopathic episodes. And we really feel very rewarded. And the second case is that of a phenylketonuria, global developmental delay, autism spectrum that is emerging. And he's just been diagnosed recently. In fact, he's from Virar. And We know that phenylketonuria does respond to special medical food if started in a timely manner. Of course, there are certain other types of compounds that are given in some special type of phenylketonuria. Uh, Reason to put these cases is how we often get disheartened thinking that it's impossible to treat these children. So even those belonging from the uneducated sector, poor sector, we have, if the parents are willing and if the physicians if we as a community are cooperative, we can help these children salvage a lot of their normal childhood. This, I did not get the consent to share the photograph. She's a child with methylmalonic acidemia. She was diagnosed on day 3 of life by newborn screening, and she followed up with the special diet since that day. And today at 6 years, she's normal with normal intellect. She's moved back to USA 2 years back, but normal schooling, hobbies, everything. And this last case, of course, is a case of autism with ADHD. He was diagnosed as a case of intermittent maple syrup urine disease. Just a word of caution, because a lot of us are seeing a lot of autism and ADHD in our OPDs. 5% of these could be due to inborn errors of metabolism, and really timely referral and collaborations are very important, because these become one of those few categories of treatable autism, if they are managed in time. That too, there are lots of caveats to it. This child also, because he was diagnosed so late, we could just give him the therapy to prevent further episodes of encephalopathy. There was marginal improvement in cognition and behavior, but starting at 7 years, you cannot really reverse all the neurobiological changes that have already taken place. Giving some other example of treatable genetic disorders, this was a girl with osteogenesis imperfecta. Prior to you can make out the blue sclera, fractures with minimal trauma. She had 24 fractures in 2 years, prior to starting bisphosphonate treatment. And for the last 3 years, she's had no fracture, and she's a smiling, pleasant child who shares small anecdotes from her school when she comes over. You can see the change in personality, the change in outlook, the familial, equations have changed. The stress levels have come down just because this disorder was treated, whereas someone had told her, don't do much. It's very expensive. It's a genetic disease. Bachche ko ghar pe rakho. There is another case. This is just to say how often we may get tricked into believing that everything that comes with enlarged joints and, calcium metabolism abnormality may just be nutritional rickets. That's not always the case. This was an interesting child, rachitic presentation, but at the outset, he had normal calcium, phosphorus, and parathyroid, and increased levels of 25-hydroxy vitamin D. And this is very, very typical. It's a hallmark feature of the genetic rickets section. We did find that the child had CYP27B1 related mutation, and we did not need to really pump vitamin D. Rather, we needed to add rocaltrol, 125-dihydroxy vitamin D needed to be added to the treatment, and he responded, basically. So this is just to say that we have more than 110 treatable causes of intellectual disability. A lot of these medicines are being made available in India. These medicines can often sometimes change. The choice of the medicine can change based on the mutation. That's called personalized medicine and precision medicine. So everything put together, we really should feel more encouraged to chase a genetic diagnosis because it may just impact the child's life positively. It's very important to understand that the government of India has broadly categorized rare disorders into 3 groups. One, which are amenable to a one-time curative treatment, like an organ transplant, thalassemia, where you do a single one-time stem cell transplant. Group B, which is diseases require lifelong treatment, but at a relatively low cost. So, for example, say congenital adrenal hyperplasia. Then group 3 comes, there is a definite treatment. It is expensive and lifelong, like enzyme therapy for lysosomal storage disorders. Now, what has happened, it's a very encouraging news for individuals with rare disorders and physicians catering to these disorders. There is a national rare disease policy, which was updated in 2021, which we should be aware of. Under the umbrella of this policy, individuals with rare disorders could avail benefit of a one-time benefit of 50 lakhs towards the treatment of their disorder. Of course, there are lots of protocols in this. Not every person can just walk to the GOI and ask them for money. There are centers of excellence which the central government has set up across the country in order to route these the petitions or the request for these drugs and for this help. Of course, there are challenges. We are coming of age, with these new policies in India. So it's definitely going to have some hiccups. But I would like to tell you that we have had some successful collaborations. Our patients with MPS 2 and MPS 6, we have routed them through a proper channel to the Center of Excellence at KEM, and with their help, both our patients of our center are getting enzyme replacement therapy regularly, and they're doing very well. One is a case of Hunter and one is a case of MPS 6. So this is just to say that, jugards are possible. If there is a will, there is a way. And really, it's very difficult to convince parents to chase the diagnosis, to spend that money, and then sometimes tell them, look, there is a treatment, but you have to go through long route of government applications. But for those few who have the willpower, they do see the the brighter side of their child's disease. This is just a very quick table. Of course, it's not all inclusive, but these are the broad categories in which we can divide the treatable genetic disorders, those in which you're replacing something that's deficient. So say an enzyme replacement, or replacing a deficient vitamin like biotinidase deficiency, replacing hormones, or you could just be doing a diet adjustment, or you could be replacing a tissue, like classic example being thalassemia. But we know that even in Krabbe disease, adrenoleukodystrophy, pre the onset of neurological onset, if the transplant is done, we can salvage the child. And of course, then drug therapy. So pyridostigmine in congenital myasthenia, penicillamine in Wilson, and so on. And of course, we are at the cusp of future. In fact, I should not even call it future, because CRISPR-Cas9 based genetic therapies have already hit the market. We understand, broadly speaking, these are like genetic scissors. I tried to have the latest updates for this talk, but I realize it's so much that I will not be able to do it. So right from the first gene therapy for sickle cell disease to the first topical gene therapy for the wounds in dystrophic epidermolysis bullosa, to an upcoming gene therapy for metachromatic leukodystrophy. The list goes on and on and on. So I think we understand that I've just spoken on one of the reasons as to why should we be diagnosing these cases in time. And that is because treatment is available for some of them, but for those some, it can mean everything. As per the rare disease statistics, yes, we have cure for just 5% of all the diseases. But, I still feel that shouldn't be a deterrent for us to not be chasing these disorders. I think I've given ample of examples as to how a timely diagnosis can help the patient. Also, one of the common refutes which come to right from the patient and sometimes the family is, a doctor is spending a lot of money. And although we know, sitting on the other end, that when they have done 100 CBCs, taken 10 admissions, not got a diagnosis, the effective cost is much more than trying to chase a genetic diagnosis. But now this has actually been proven that there was a economy-based study which was done, and they showed that if these tests are done in a timely manner, obviously this was done for neurometabolic disorders, it actually saves $19,000 per family. Because what are you treating, rather than just giving empiric treatment and really being a health economic burden for the state as well as for the families. And it also saves 6 to 7 years on an average per family, because they know what are they dealing with, and the time is not lost in just getting a diagnosis. The third is, of course, needless to say, in a country where still marriage is very popular and having children is such an important aspect of the social life, that preventing recurrence in the next children is of paramount importance. And very often, even the general man who doesn't know anything will say, डॉक्टर कुछ तो जीन्स में गड़बड़ है, क्यों बार बार हो रहा है, कुछ तो हमारे में गड़बड़ है. Look at this family, consanguineous, 3 babies they lost back to back. All of them had the colloidal spectrum. We call it as MEDOC, Mendelian disorders of cornifications. But the point was, someone did their parental karyotype and told them, don't worry, it's normal. That is one message I wish to stress upon. A couple karyotype being normal doesn't rule out all genetic diseases. In fact, it rules out nearly none, barely 1% of all the genetic disorders. These are gene level errors. It's like telling I've screened the building from outside and I know that there is no robber inside. No, I need to go inside and open each and every door. So you need special gene level test for this to detect the mutation. In this case, we did get the mutation. And then, of course, you can counsel the family about their options. Either they can choose to get pregnant and then check the baby. If the mutation is present based on the severity of the disease, their personal beliefs, cultural beliefs, they may want to continue the pregnancy or discontinue it. Of course, we have another option called preconception genetic test, where these embryo is made, the biopsy is done, and then those that are not affected, only they are implanted into the mother's womb. And currently, as of now, also we have 3 couples, one with thalassemia trait. So they don't want a baby with thalassemia, and they've already had few unfortunate experiences in the past. One family with Marfan syndrome. So this is not something that's not done. Preconception genetic test can be offered. Of course, there is a caveat that it is much more expensive as compared to the prenatal test, but it saves the couple the psychological and the emotional trauma of getting to know about an affected child and terminating it at 4th month of pregnancy. The 4th reason why we should be picking up these disorders in time, even if there is no cure, you can always give better care. Correct? So DJOT syndrome, for example, there is no cure for it. But I know it's associated with a spectrum of associations which can individually be managed medically. Hypocalcemia, if the child has severe immune deficiency, don't give live vaccines. They could have auditory visual concerns which can be corrected under, we know how it affects the intellect. Duchenne muscular dystrophy, again, although there are these antisense oligonucleotides and all available, they are not really exciting in terms of end result and actual impact. But even despite that, timely physiotherapy, occupational therapy, respiratory vaccines, 2D echo to prevent cardiomyopathy, you would never know that and offer that till you don't know what are you dealing with. So if not for cure, at least for better care, getting a complete diagnosis is very important. This was one of our patients who had congenital insensitivity to pain, barely less than 1 year, but she had actually bitten off her entire fingers. And as a part of the recommended way to deal with it, that this child needs to be, all the teeth needed to be removed out. So that she doesn't cause there were times when there was torrential bleeding from the finger. So these children have insensitivity to pain, and even if you kind of amputate the finger, some of them would not feel any pain, and they have self-injurious behavior as a mode of self-stimulation. This was one of our patients with Soto syndrome. You can see he's so overgrown. He was barely around 10, 11 years old. And why it's important, like in this case, I have not treated Soto, but I know 3% of the Soto due to NSD genes variants can be associated with tumors. So I'm going to tell him, look here, you need to undergo so-and-so surveillance. I can't treat your Soto, but if so-and-so cancer comes up, at least we can pick it up in time so that your life is not at threat. So this is the 4th reason. Of course, the 5th reason is, I think genetic medicine comes closest to family medicine, because we never look at just the patient, it's the entire family. Even for something like dilated cardiomyopathy, we often see a lack of translation of the information that the mother through whom the mutation has come, 1/4 of them could be at risk of dilated cardiomyopathy. And these parents have spent their entire life worrying about the child, that very often just doing a routine screen for the mother, so that if she's developing dilated cardiomyopathy, she could be put on some medicines. This aspect gets totally ignored. We understand even this impact, although I know that may not be common as pediatricians, but there are cancer predisposition syndromes where often after the child is detected, you realize that, oh, the parent is carrying the same gene and you need to put them on a surveillance protocol. Female carriers of Fragile X syndrome are at a risk of premature ovarian failure. We had a family where we had to tell the lady, After the child got diagnosed with Fragile X, she checked her AMH values. They were really plunging down. And with that information, she planned her baby quickly. Sometimes they may opt for fertility preservation, OVA preservation, so that they can have a baby at another date. So this is the impact. Till you don't know what's happening, how are we going to be able to cater the benefits of the diagnosis to the family? Of course, and sometimes it may happen that you've got a diagnosis, there is no cure, there is no care, there is no benefit to anyone involved. But even at such times, closure, prognostication is a big takeaway. Simple example, Angelman syndrome. These are children who have severe speech delays, so much so that parents who come to us, we tell them, look, don't spend your time on speech therapy. Instead, target what is called as augmentative and alternative communication, which utilizes facial expressions, body language, gestures. Train them in that because they are never going to speak. So why waste your time and money in go and chasing another modality of treatment which is not going to give you results? Again, bilateral CTEV, there are many disorders, right from myopathy to skeletal dysplasias to neuropathic disorders. Should you be operating all of them? It's very, sometimes you see families who come at 4 years, 5 years with a myopathic child, no milestones, but the CTEVs got operated very nicely at around 6, 7 months of age. So do we need to operate all these birth defects? Are there underlying syndromic associations? Is there a larger picture which we are missing? And I think finally, if there's nothing else, getting a complete diagnosis can sometimes be the beginning to, beautiful stories. And one of them is the story of Pehel. As I feel the change starts from us. I can never stop thanking IAP Palghar, Dr. Anjali Gokarna madam for the support that they had given to start this wonderful initiative for children with Down syndrome. Pehel, as we know, is a parent and expert forum for health and excellence in life for children with Down syndrome. Right from health camps to parent expert talks to activities, we are having a meeting on 21st of March where in an indoor gym club, we'll be all having play activities with the children. So support group, for the parents to feel connected with others of the same community. Again, a diagnosis is important. And last, I think if in today's day nothing scares us, the word medico-legal has become the Gabbar Singh, So I'd heard a joke that you see a case first legally, then medico-legally, and then medically. So in a recent survey of ENT malpractices, failure of duty to refer was a second commonest cause. That if, as a physician, we feel that this could be in the realms of a inherited disorder or a genetic disorder, I think multidisciplinary care is the next thing forward, and that is how we can give the families holistic answers. So this is just to very, very quickly summarize what I have said. I would not want to waste a lot of time repeating it. I'm just going to end with a very small anecdote, and I'm sure some of you all must have heard it. There was once this young man who was picking up starfishes, so with every high tide, there would be lakhs of starfishes that would come on the shore and they would be left back. And then the tide would keep receding back. And this young man who was taking a walk kept picking up one starfish at a time and throwing it back into the ocean. And there was someone else who was walking down the beach. And they said, there are millions of starfishes. How many of them are you going to save? Do you even think it makes a difference? And this young man just picked up one more starfish, threw it in the ocean, and it said, I know it made a difference to that starfish. So I think we have to start one case at a time. I'm very happy and to share the work that we do at the Purple Gene Clinic. We try to cater to patient care with all our efforts. We try to engage in academia, social care initiatives. We have very active training and observership programs and a lot of collaborations with research-based genetic testing. So we are actually very happy to be a part of so many family lives, who have rare disorders. And actually, it's inspiring to see their grit sometimes, to see their happiness when their child has attained some so-called unattainable milestone. And I think it's a journey, and together we can make it very beautiful for all of us, for the families as well as for ourselves. I think with that, I will stop the screen sharing, and yeah, I have finished the talk in time.
Thank you, Dr. Shruti. It was a very informative and very precise on time lecture. Can we take few questions, Dr. Shruti?
Yes, ma'am. Yes, Anjali, ma'am. Yeah.
Yeah. Can I start with a question? What is the contribution of cord blood banking? Is it helpful? I
No.
mean, it's very
There is a
costly. So
paper by Indian Academy of Pediatrics, I think nearly 3 to 4 years back. I think it was when Dr. Samir Dalwai was the president. They had removed a statement, and I think Dr. Mamta Manglani is on the group, which says that there is no role of cord blood banking, and answer is no. So if there is a very specific scenario, and say even if the parents have not banked the cord blood, the siblings' bone marrow can still be harvested even from iliac tap or other regions. So answer is no, there is no compulsion on it.
okay. Or if not cord blood, is there anything else you recommend what should be done? What do you
No,
recommend?
don't bank anything. Put the money in the bank for the child. Don't put the stem cells. That's it.
Okay.
Because there's nothing that we can do right now. Yeah, that same money ka FD kar do and give it to him, him or her. So see, there are, of course, in the guidelines, they have mentioned that there are public sector cord blood banks. So even if the parents are insisted, we should be going over there rather than the private sector, because the public sector cord blood banks are like a blood bank that anyone can go and avail of it. So it's not driven by commercial logistics. So answer is no, and that paper is freely available. You all can address it. It's a very nicely given, crisp paper. Yes, ma'am. Yes, Anjali, ma'am.
Yeah, Shruti, some years ago, many years ago, when I was an undergrad, when I was doing my post graduation, I had seen a child with congenital absence of pain. That was a little. There is some other illness also where they get multiple fractures and they don't realize it, or
Many, ma'am. So, ma'am, the spectrum ranges. This is just one of them, SEPA, what I told. But there are many neuropathic conditions, autonomic neuropathy. The spectrum is very large, where insensitivity to pain is just the symptom, but it's genetically very heterogeneous. So it could give rise to, so like what we explained, that child has fever, but there could be multiple bugs causing it. In the same way, insensitivity to pain now has a lot of genes that have been discovered, madam. And although honestly there is not, but we saw how in the pipeline there are so many new products coming up, how there is a government policy that's willing to help. So if we can give the family the name of the gene, the confirmed diagnosis, at least they are prepared, so fortune favors the prepared, basically. So if they know the gene, of course, if they're planning another child, that's another story. But even for this child, there are things which... Yeah.
Yeah, please go ahead, Shruti.
Yeah, ma'am. That's it.
Yeah.
Dr. Shruti, I want to ask you, apart from high index of suspicion, and probably not everywhere we can do metabolic studies and all that, is there anything else in blood workup we can pick up these cases early? I mean, just for
Yes,
referral sake.
Yeah, so actually I like to sum it up with this easy mnemonic: family genes. So when there's a family history, of course, you have to suspect genetics, but 75 to 80% of these disorders won't have a family history. So absence of family history doesn't preclude a genetic diagnosis. Family genes, G is group of congenital anomalies. If you see a group of congenital anomalies, think of a genetic disorder. Even the most seasoned geneticist may not always be able to tell you as a spotter, but starting the process is important. E is extreme manifestation of common symptoms. So we see a child crying after vaccines. But if that crying goes to an encephalopathic episode, this could be due to SCN1A mutation. So extreme things. So extreme 12 fractures in 1 year by just someone pushing. So these are examples: extreme myopia, extreme obesity, extreme tall stature, extreme short stature. So E is the extreme manifestation of common features. N is neurological. I think if you remove infection and trauma out, there are very few things that remain in neurology, and that is the case because brain and muscles form the topmost region that are affected by genetic disorders. So that's the N part of it. E part is extreme pathology. So extreme hepatosplenomegaly, extreme failure to thrive, extreme pathology, and the last S part is surprising lab values. To answer your part of the question, Dr. Wasim, there isn't a single test that I can screen and tell, oh, this child may not be at a risk of genetic disorders. In fact, even with the highest available genetic test today, we can decode barely around 50% of the rare disorders. The remaining 50% still don't get an answer. But I think, like I gave you the example of rickets. So going back to the pre-treatment records, simple things. If we are seeing an anemic child, HB, So I think case-based, looking at surprising lab values. We once had a phone call we had sent. It was a child with developmental delay. And then someone called back, the lab called back saying the sample is very lipemic, and we did the triglycerides, cholesterol, and it turned out to be a sphingolipid synthesis disorder, basically. So that's just to say how we need to keep our eyes and ears open. Very often, these D. Georges who come to us have history of neonatal seizures, hypocalcemia, but maybe because heart disease was not there, it wasn't looked into. But if with hypocalcemia, you're finding hypoparathyroidism, then that is very classical of D. George. And by the way, D. George is as common, nearly as common as Down syndrome, with an incidence of 1 in 300 to 1 in 400. In fact, guidelines more than 15 years back say every child with tetralogy or fallow, one should be doing the D. George deletion. This is just digressing from the topic, but it is saying how we could be missing so much that's coming in our OPD already.
Thank you, ma'am. Thank you. That's
Yeah.
Shruti, fragile X syndrome is one of the commonest causes of mental retardation. Can you tell us any clinical pointers for this?
So, ma'am, there are two extremes of fragile X. So, it is the commonest inherited cause of mental retardation. The commonest genetic cause of mental retardation would be Down syndrome, basically, because that is not inherited, that is sporadic. Now, coming to fragile X, a child with fragile X could be like just any other child having autism ADHD with no red flags at all. But sometimes some of the red flags could be recurrent otitis media, squint, soft velvety skin, test planus, a cardiac anomaly. So these could be, and the typical facial features of prognathism that comes up in the pubertal, post-pubertal macroorchidism. So very often pediatricians won't pick it up, the facial profile at least, so we should not, presence of features is a red flag, but absence shouldn't deter us. Also, I've seen that we'd seen a family pedigree where multiple female side relatives had autism, intellectual disability, hyperactivity, because Fragile X is a X-linked disorder. Asking for history of premature menopause in the family and other members on the female side, of course, without singling out the mother, asking both the parents. But if you're finding a pattern of female-sided relatives having these things, these are the early red flags of suspecting Fragile X.
Thank you.
Yes,
that's really helpful.
Yes, yeah.
So, are you going to share the PDF of your presentation?
Ma'am, I will share some because there are some photographs where I've put also
so
that these
are the photographs, but we definitely need the textual matter. If you can share.
Sure. Yes,
and
yes. So
also,
just give me. Yeah, sorry.
Yeah, by tomorrow, there's no hurry.
Yeah. Just give me 1 to 2 days, ma'am. I'll delete all the photographs, make a PDF, and I'll share it if it helps. So definitely I'll do that.
Also share the address of your clinic so we can, refer patients for betterment.
My pleasure. I'm just available a phone call away, and I'll be very happy. I get to learn a lot because each of these patients, some are outliers, some are typical presentations. And I think all the referrals that have come from all the colleagues over here have really helped us learn so much and grow at a steady pace. So really thank you everyone for this opportunity and for always, helping us be a part of your team.
Thank you, ma'am. Thank you so much.
Thank you.
Archana, ma'am.
Yes, Wasim.
What what will we take next now? Next topic?
We are taking Dr.
I-
Akash now.
And your topic, ma'am. Yes, ma'am.
Yeah, we will take Dr. Akash later.
Okay.
Akash, all the best.
Sir, I'm not able to share my screen.
Yes,
Hello.
Dr. Akash. All set?
Sir, good afternoon. I'm not able
Good
to
afternoon.
share my screen.
1 second.
आणि शेअर स्क्रीनचा ऑप्शन असेल बघ ग्रीन कलरचा आहे
Has Dr. Shruti logged out? So then maybe if she's not logged out, then maybe you're not able to share the screen probably.
But it's showing, sir, host disabled participant screen sharing.
Okay.
अच्छा
just let me-
पल्लवी मॅडम
Sir, try sharing now. Akash sir, you are co-host now. Just try sharing again.
हा झाली
Yes.
Started sharing.
So, good afternoon, everyone. Today's my presentation is on infantile colic. So, myself, Dr. Akash, and I'm currently working as assistant professor in Nair Hospital, Mumbai. So crying, we all as a pediatrician have and physician have seen the babies all the time crying in the OPD, and parents are with coming with all complaints of the child is not stopping at all, is crying all the time and all. So crying is considered as an essential behavior. The way the child is communicating, the baby is communicating with the parents or with the environment to fulfill his needs and demands. So actually, it's a good signal, but poor signal because we don't know what the child needs. So prolonged crying or fuzzing, particularly unsuitable crying, is a source of anxiety and distress for the parents and challenge for the doctor. So a 12-year-old can ask when he's hungry, when is the dinner, I'm starved, but a 2-month-old will cry. When there is overstimulation, a 12-year-old will ask, leave me alone, but a 2-month-old will again cry. So these are the just ways of baby to as a cry to communicate with the parents or the environment. So the thing is, the crying is normal. Baby cry for many reasons, and all babies will have times when they cannot stop the crying. So there are 3 types of babies. We'll classify baby who cry less, average baby, and babies who cry more. The baby who cry less will maintain the plateau of crying less than 1 hour per day from their birth to the 14 weeks of life. While the average baby will cry for at least 2 hours and has small peak at the age of 6 weeks, and then plateau at 8 weeks, and again achieve their normalcy at 14 weeks of age. However, the babies who cry more will have peak at the age of 6 weeks, and then they will achieve the plateau at 8 weeks, and then again follow the 14 weeks. So same baby and same day. At some period of time, over a period of day, the baby will smile, the baby will play active and playful, while at some period of time, the baby will cry. Is whatever the parents will do, whatever the relatives will do, the baby will cry without any obvious cause. So, is there any difference between crying curve for premature babies or term babies? It's like there is no difference between infantile colic in a premature babies or mature term babies. However, the quality of crying is different. So, how will you define the colic? The colic is a violent, rhythmical, paroxysmal, higher pitch, often unpredictable periods of prolonged crying, which occurs in a bouts, and it raises the soothing beer. Whatever makes it so hard, the child will cry with, and it associated with violent shaking of the body. He will draw up the legs over the abdomen and associated with flushing of the face. So in Asian cultures, it more likely to be viewed as a normal part of development. The Chinese will label it as a 1,000 days of crying. The Japanese will say it is a winning crying. The Vietnamese will say the 3 plus 10 days of 10 days of crying. However, this problem occurs in middle class families or Caucasian parents. They tend to report it as a colic and they will seek the help. So we just have seen the definition of what is the colic, which was first given by the Neil Rosen in 1764. However, this development, a variant of normal development, it is this term is given by the Ellingworth. So first definition and the first diagnostic point is given by Wiesel's rule of 3, which says the child will cry for more than 3 hours per day and more than 3 days per week and for more than 3 weeks without any apparent cause, and the child is growing and feeding well. But the flaws with the Wiesel's rule is that it will tell the parents to wait for 3 weeks, which is practically impossible to wait for 3 weeks and tell them to just monitor the baby. So again, there are some certain modifications we have done in the Wiesel's criteria, and the criteria is given by Room 3, which states that which is for all the infants from birth to 4 months with periods of irritability, fuzzing, crying that starts and stops without any obvious cause. Again, same, lasting for more than 3 hours per day for more than 3 days per week, but only for 1 week. And also same criteria, not associated with failure to thrive or feeding problems. However, again, Room 3 criterion modifications were done under Room 4 criteria because it has not defined the colic as a functional or non-functional disorder, because later it was realized that the colic is not associated with only gastrointestinal problems. So it is labeled as a functional gastrointestinal disorder, which is defined by the Rome Pro criteria, and they removed the more than 1 week duration. The colic is not linked to the birth order, gender, feeding style, number of babies, and it can occur in a healthy baby also. So what are the various theories related to colic? Because no, there is it is more than 150 years the definition of colic was given, but no single theory has yet to be able to discover the underlying pathophysiology of the colic. So what are the various causes? First cause is milk protein allergy, cow milk protein allergy, lactose intolerance, food allergy, immature nervous system, maternal anxiety, bacterial imbalance, and gas. But the infantile colic is a diagnosis of exclusion, because if there are certain conditions that we have to first rule out, such as interception, volvulus, strangulator hernia, torsion of testes, corneal abrasion, and non-accidental injury. And there are certain disorders which mimics like colic, like seizures, infantile spasm, cerebral palsy. And there are certain discomfort such as too hot, too cold, too itchy, nappy rash, and woman's diet if breastfeeding, if she is taking excessive coffee, tea, soft drinks that contain caffeines, that also irritates the child. So what are the various diagnostic tools? These are for research purpose only, not for a clinical use. The baby day diary, MS cry thrower, parental diary of infant cry and first behavior, and crying pattern questionnaire. In bar baby day diary, they have divided the 24 hours into 4 charts: night time, morning time, afternoon, and evening. And each 6 hour is again classified in the 6 blocks by 1 hour pattern. And there are some certain baby codes in the form of sleeping baby, awake and active, awake and fuzzy, awake and crying baby, and awake and feeding. So we have to manage the colic. So the goals are to soothe the baby, crying baby, and to relieve the parental anxiety and stress. So first line of management is parental reassurance that this type of crying is normal physiological behavior of the baby, and it's not something wrong with the baby. It's just a baby's way of communication with the parents, and it will pass over a period of few months. So there are 5S technique that parents can do, like swaddling, side-to-side movement, making sound, swinging the baby movements, and sucking on the nipples or a pacifier. The letter purple, we have to explain the parents that which defines the infantile colic. The P letter stands for peak of crying, and which the peak can be more at the age of 1.5 months, 6 to 8 weeks, and it is unexpected crying, and it resists the soothing. The baby will make a pain-like face, and it is long-lasting for more than 3 hours a day, and it is more during evening time. The second line of management is medical treatment. Only this can be considered only when the behavioral modification has been failed. The first is we commonly use simethicone drops. The simethicone contains silicone compounds, and it works by decreasing the surface tension of the intestinal gases, so that the gas will pass through the intestine, and there will be pain relief. However, it does not reduce the gas formation in the colon. However, only few studies have shown the benefits, and the number of cases were also less. In some cases, it has shown that if the child is a case of hypothyroidism, the simethicone will oppose the action of levothyroxine or decreases the absorption of levothyroxine. Second is dicyclomine drugs. We have seen that because of immaturity of the enteric nervous system of the baby, there is intense smooth muscle spasm, which will opposed by the action of dicyclomine. But the adverse side effects which are seen in less than 6 months of age associated with dicyclomines are apnea, seizures, and coma. So it is not recommended in less than 6 months of age. Next are the proven role of probiotics. There are so many studies which are working on the effects of probiotics in treatment of infantile colic, because the normal human probiota is achieved by maternal commensal and maternal during the mode of delivery will also decides the gut flora of the baby. So there are certain harmful bacteria and there are good commensal bacteria. So bacteria like Bifidobacterium, Lactobacilli are the normal commensal which will prevent the colonization of the harmful bacteria like Propionobacterium and E. coli. Also, this lactobacillus is proved to be effective in immunomodulation in the local intestinal mucosa. There are other proven benefits of lactase enzymes. So if we premix the breast milk or any other formula fed with lactase enzymes, it has shown some benefits only certain studies, but large scale studies are still remaining. There are certain herbal remedies, but it has not FDA approved, like such as chamois and fennel and balm mint. But it has some certain antispasmodic properties, but it has not been approved by FDA. there are certain hypoallergenic formulas which we can baby or babies on formula fed, but large scale studies are still lacking. There are certain studies to recommending soy-based protein formulas, but it should not be used if the baby has history of cow milk protein allergy, because soya also acts as one of the allergen for the baby.
Akash, can you talk a little louder?
Okay, ma'am. Hello.
Yeah.
So there is again a role of maternal diet. If the baby has a history of atopy in the form of atopic dermatitis, and along with that, if there is a history of infantile colic, the maternal diet should be changed. If the mother is taking cow milk in her diet, then we can stop it for at least 2 weeks. And if there are effects decrease in the infantile colic, then the mother should eliminate her cow milk from her diet. So how long does this colic last? It will, in 100% of babies, it starts by 3 weeks of age, but the end varies in infants. So 50% will resolve by 2 months, 80% by 3 months, and 90% babies will have improvement by 4 months of age. There are certain studies which has proved the development effects of this infantile colic, such as motor and language, behavioral problems in the form of they will get temper tantrums, they will have sleep disorders and hyperactivity. So in summary, colic is a common condition that affects the healthy baby. Normally it soon starts after birth, lasts at least for 3 to 4 months of age. Sometimes in 10% of babies it will last around 6 months of age also. It can affect 1 in 5 babies. The prevalence is globally, the prevalence is from 3 to 20%. And this is because there are 20 to 30 studies which are done on prevalence of this infantile colic, but the definition and the cutoff of the crime, they have not fixed in all studies. Because of that, the global prevalence is varies between 3 to 20%. And in the last, there is no specific treatment. The best treatment is parental reassurance with the 5 years technique. Any questions?
Wonderful. Can you stop sharing, please? I have a question.
Yes.
Yes, ma'am.
Yeah, sometimes some children cry so much. I wanted to know about simethicone. I'm sorry, I wanted to know about dicyclomine.
Ma'am, the dicyclomine acts as an antispasmodic agent, but in a certain doses, and also there are many studies which are not done in less than 6 months of age. So if you are prescribing the dicyclomine, in some cases we might see the apnea and bronchial obstruction in already asthmatic babies or having history of hyperreactive air vessels.
Okay, Akash, can you hear me?
Yes, sir.
Can you hear me?
Yeah, Nilesh,
Yes,
go ahead.
My question is very basic. Why the colic stops after 4 to 6 months? Is there any reason? We see drastically.
Maybe it is associated with the maturity of enteric nervous system, and also the development or the quantity of lactase enzymes in the intestinal epithelium might be increased after that 4 to 6 months of age.
Okay.
Yeah,
Are there any
Dr.
home
Nilesh, I would like
remedies?
to add to that use of digestive enzymes does also help in a lot of colics. And previously, we used to get a molecule called as anafortin drops. I think it's campylophorin. I think so, if I'm not mistaken. Anafortin drops. So they were more safer than dicyclomine, and it had a dual action, anticolic and smooth muscle relaxant at the same time with no side effects. I think it's not available now, I think so. But they were much safer through dicyclomine, I think so.
What is the can we use crucin? Like, what is the stand of IAP or practicing pediatrician to use crucin for
Paracetamol.
paracetamol?
Paracetamol, no role. No role.
I use as a non-specific pain relief analgesic. I do use.
I also do use, because then you don't have much to offer.
Correct.
So I still
Archana, what is
remember.
your?
Yeah, I
Just
still
asking.
remember. Yeah,
I think
remember.
many a times when there is a confusion between whether it's a earache or a colic, then the paracetamol may be a little helpful, because we are a little confused. Sometimes they have earaches also. So
And what is the take of that lactobacillus reuteri? Like, I have used in number of cases, and many a times I found it's helpful. But I don't know what is the experience of other pediatricians, because it is a
it is
costly.
quite helpful. Quite helpful.
Yes.
Dr. Akash, what is your?
Ma'am, there are more studies on the probiotics than any other, like formula fits or hypoallergen formula, and compared to all other these things, imethicone, dicyclomine, probiotics use has been found to be beneficial in case of infantile colic compared to other things.
So, is it possible to bring that probiotic first on the line and saving the pain and then the time what they spend on OPD? So, is it possible to bring probiotics first on the line rather than simethicone and then crucin? What do you feel?
Sir, before that, the parental reassurance is the best thing, because it is cost effective without any side effect. And if that is not happening in that case, then the next management would be probiotics.
Okay.
Can I share something?
Yeah.
Yes.
Wonderful presentation, Dr. Akash. But I just want to say one thing, that this shouldn't go in the public, that whenever there is a colic or whenever there is excessive crying, you give all this simethicone or whatever we have discussed. Because in the so many years, we have picked up kids with excessive crying, with meningitis, with UTIs, with AOM. So it would be my request that first we do all the investigations. And like in one of the conference, I had heard Dr. Uma Ali that all kids with excessive crying, most of them are presenting as UTI, and we are just missing those excessive crying babies. And the baby, by the time they are reaching 25 to 30 years, they have gone into chronic renal disease. So madam was like, all excessive crying, you please do a urine routine test and rule out UTIs. That is only what I want to say. Ki first, labeling a child with a colic, we should first rule out everything from head to bottom, and then only label a child as colic, because we have seen many uh, children who have been given these things and turning out to be some grave diseases. So it is a request ki before prescribing things, first rule out the other things. I want to say only that much. Yeah.
Yeah, well said, Vaibhavi. Yes.
So from today onwards, I will do urine routine micro if a baby comes with cry. So that I'll implement.
Yes. Like in febrile convulsions, we are doing urine routine for all the patients, because most of the febrile convulsions are turning out to be UTI. And there was a paper presentation for this also, ki all febrile convulsions should have a urine routine done to rule out UTI, and most of them are having the same. So like in colic also, I think we should do all the tests and then label the kid as a colic.
Yeah,
I think
cases of in our clinical practice, we should have an otoscope. It's a very useful thing for ear inflamed tympanic membranes and issues. Many a times we can reach a diagnosis with that also, ear examination.
So for all fevers, we should see urine. For all fevers, we need to rule out urine.
Yes.
Unless we find some focus staring at us like tonsillopharyngitis. If we can't find anything, we must go for urine examination.
There is one study, ma'am, which recommended that even if there is a febrile cry in a less than 1 month old, we have to do urine routine microscopy.
Yes.
Okay, less than 1 month, a baby is having a cry, then a urine routine micro.
Febrile cry, sir. Even if it is a febrile cry, then we have to do urine routine microscopy.
But we had picked up this meningitis and UTIs in the kids who were afebrile and only had excessive crying as their presentation. So because in newborns, fever is not detectable so early, and they have afebrile. They are afebrile with these diseases.
Excellent discussion, Dr. Akash.
Ma'am.
An unusual topic to take up and a very everyday common topic.
Yes.
Thank you.
Thank you.
Thank you, sir.
I think, Anjali ma'am, are you ready with your complications of post-mumps? Okay,
Yes.
ma'am. Shall we go ahead?
Yeah. After two lovely talks by Dr. Shruti Bajaj and Dr. Akash, we now go to a presentation. And first, I wanted to just present last month, or rather this month, from 9th to 11th of February, we had, can everyone see this?
Yeah, yes, ma'am.
Is my screen visible? Yeah. Thank
Yes,
you,
yes.
Vasim.
Yeah.
And we had a neonatology conference which was organized by Thane Academy of Pediatrics, Palghar Academy of Pediatrics, and the Hippocrates. This is a a yearly event that was first for the last 20 years we used to attend at Bangalore, but this year our dynamic Dr. Shailesh Barot and Dr. Samir Sheikh and Dr. Parmanand Andankar undertook this challenge of hosting it at Mumbai. And we had this wonderful 2.5 days feast of neonatology. And we had some awesome speakers. This is Dr. New, this is Dr. Maximo Vento, this is Dr. Polin, this is Dr. Lauren, and this is Dr. Pierre from various parts of USA, UK, France, and Sweden, and they were excellent, all 5 of them, over the 3 days that were hosted at Jupiter Hospital in Thane. They deliberated on various topics about the recent advances in neonatology. And this was the lamp lighting ceremony with the CEO of Jupiter Hospital and Dr. Shailesh, Dr. Andankar, our Dr. Dynamic, Dr. Archana Joshi. I really hats off to Dr. Archana and Hemant Joshi's energy levels. And we had a host of other friends, Dr. Amit Samant in the background, Dr. Anant Itkar, Dr. Mahesh Mohite, then the president of Thane IAP, Dr. Deshmukh. So this is the wonderful crowd that was there, and the wonderful ambience, awesome food, wonderful audience interaction, so many questions, and every question was answered with so much patience and with so much diligence, and they never hesitated to say that we don't know something about a topic. And we had a wonderful everything was wonderful. So if I say wonderful so many times, it's not an exaggeration. There was Tarpa dance, which was organized by Shailesh all the way from Manor. From where did they come?
Boisar.
From Boisar. And everyone joined in the dance, and all our dignitaries were also dancing. And this was awesome fun. And one of the lady, of course, she said, I want to do henna. And she insisted. And on the last day, between her first and last talk, she got mehndi put on her hands. And she so sportingly wore a sari as well. And she not only did that, she took some henna home and she put it for her daughter, and her daughter also enjoyed the whole thing. So this was the fellowship, and our president was there on the first day, Dr. Jayashree Deshpande. She was there for the inaugural session, and this is a lot of bonding with all the members, and an event which we will remember. There were 120 delegates who went back with very, very lovely memories, and they want to have it hosted every year at Mumbai, and that will depend, of course, on these two. And Vaibhavi has been a solid rock support for her husband, who spent a year, planning this meticulously. So we thank Shailesh, Vaibhavi, we thank Dr. Samir Sheikh for his wonderful participation in the whole thing. And of course, Dr. Parmanand Andankar, who got us such a wonderful venue. The food was awesome, and this was an event to remember. So thank you so much for all those who made IAP Palghar proud, and hope to have many more such conferences. So that was about Hippocrates. And today I will go on with my case of mumps and its complications. So can you see the screen? No, I don't think.
No, madam.
Not yet. We could see a Hippocrates screen. Now there's no screen share.
Okay, I'll just share. I don't know where it's going. Something has happened. So can I request Dr. Nilesh to start his sharing, because I can see Dr. Vadkar is also there. So I don't want to keep Dr. Vadkar waiting. Dr. Ankit is also going to, let me stop sharing and then again start sharing and see if I can. No, I can't see my presentation of mums. So I'll have to open the presentation and start again.
Okay, we'll take the next session and then we'll get back to you, ma'am, again once we'll do that.
I think we'll do that.
Okay.
Yeah, thank you.
Okay, ma'am.
Pallavi, can you share the presentation of Dr. Nilesh?
Yes, ma'am. Yes, ma'am. Yeah. Ma'am, is it visible?
Yes.
Yes,
It is visible. Yeah.
Yeah.
Okay. Good afternoon, everybody. Can you hear me, everybody?
Yes, sir. Yes, sir.
Yeah.
Yes.
So I'll just like to present a short case. A 7-year female, SH, resident of Virar, was brought by relatives with chief complaints of fever since 5 days, moderate grade, without chills, inability to stand with and without support since last 2 to 3 days. Initially, she had difficulty in going to washroom, and eventually she started refusing to get out of the bed. Parents also noticed involuntary movements more of upper than lower limbs. They were non-specific, non-repetitive, and they lasted for a few seconds only. At the same time, parents noticed that there is some difficulty in chewing and swallowing in last 2 days. Her speech was also affected to some extent. Her oral intake reduced significantly in these days. At the same time, she has become irritable and short-tempered. Her sleep was also disturbed. So relatives were not able to understand actually what is going on with the baby. So they visited to a general practitioner, and then the child was referred to us. Uh, then, after taking detailed history, we realized that there is no history of any convulsions, there is no history of bowel and bladder incontinence, no history of significant trauma, no history of medication for vomiting. There is no history of dog bite in the past. And then, can you put a next slide? Okay. So in the past history, there was a very positive history of mom 7 to 8 days back of this episode and was treated by a family physician. There is no history of measles in the past. There is no history of TB contact. There is no history of neurological disease in family. There was no significant travel history. Immunization was complete till age. Birth history was not significant. There were fewer vegetarians. Anthropometrically, her weight was only 18 kgs. On admission, general physical examination, she was poorly built, moderately nourished. Temperature was 97 degrees Fahrenheit. Pulse was on a higher side, 118 per minute. Breathing was on little higher side for her age, 40 per minute. Although saturation was normal on air, blood pressure was 100 by 70. Again, it was normal for her age. There was no obvious rash or there was no obvious any neurocutaneous marker. Can you shift the slide?
Next slide, please.
Next slide. Yeah. Then I went to a general systemic examination. Higher function, she was conscious but irritable. She was oriented to time, place, person. Her short-term and long-term memory was intact. Speech was, there was some nasal twang and speech was slurred. Cranial nerve, obvious left lateral rectus palsy was very obvious. Her left eye was deviated towards the nose. A hypotonia was there more in the lower limbs than upper limb. Power was grade 3 to 4 in lower limbs, grade 4 to 5 in upper limbs. Plantars were unequivocal. DTR, she was not very cooperative. There were no obvious signs of meningeal irritation, but her gait was unsteady, spine was normal, and uh, rest systemic examination was unremarkable. So my impression was the illness was acute onset with a moderate grade fever, altered behavior. Definitely there is a loss of balance along with involuntary movements. There was a definite history of dysphagia, nasal twang and slurred speech, hypotonia, left lateral rectus palsy, history of mumps in the last week, and she was poorly built and moderately nourished. So my working diagnosis with this history examination was like mumps meningoencephalitis. So some things I kept in mind, whether it is a viral cerebellitis, definitely because fever is there and some CNS manifestation, pyogenic meningitis, tuberculosis meningitis I had to rule out. And definitely ADM comes in the mind, but it is always by exclusion. So then we did blood investigation. They were bit normal. CSF was not very much conclusive. It showed WBC count was around 30 and lymphocytic predominance. And then we went ahead with MRI. And MRI, it took a half a day or 1 day to tell ki it is a acute demyelinating encephalomyelitis. The parent brought the MRI films to me and then they asked me, sir, what the MRI looks like. And then I went through and then I didn't didn't get anything in the MRI. And then I told I have to wait for the result to come. And after done CSF, we started with monosef, and then we waited for the MRI report. And in between, we communicated with Dr. Watkar, and then he told me it looks like acute demyelinating encephalomyelitis, and then he advised us to start with methylprednisolone, and then he reassured us that methylprednisolone works wonderfully and the child should settle down in coming 2-3 days. And then we finished the course of methylprednisolone for 5 days, and then we switched over to oral prednisolone, and then we handed over that case to Dr. Amit Watkar to follow on OPD basis. So as a primary care pediatrician, I thought ki it looks like a mumps and mumps related CNS manifestation, but what was not fitting into it is obvious left lateral rectus palsy, which was not fitting exactly into the mumps and its related CNS manifestation. And then second thing was in my mind is ADEM. But then if you want to diagnose ADEM, then you require MRI, and then you require normal CSF or non-specific CSF. So I think putting ADEM clinically is not that easy unless and until it is supported by your CSF and MRI. But nowadays, I have come across many cases of ADEM. So a child comes with not very specific CNS manifestation, and if they are scattered, eventually it turns out to be ADM. So I think this is my third or fourth case of ADM. But first case which I managed before three cases I referred to Vadia, and then they treated with methylprednisolone. And because of Dr. Watkar only, I could gather that courage and to manage the case of ADM. Before that, all the cases we straight away we referred to Vadia. But maybe this time we could do it just because Dr. Watkar's support was there. And that was a good experience, and the child did well. After second dose, I think the child involuntary movement reduced. By third dose, her lateral rectal palsy was reduced a bit. By day 4, she was able to sit in the bed and go to the washroom, and I think by day 5th she was quite playful. Now she's having a follow-up with Dr. Watkar, so Dr. Watkar knows how she is doing maybe. I'll just run through with some theory part of acute demyelinating encephalomyelitis. A previous slide, please. Now they are labeling it as a acute disseminated encephalomyelitis. Initially it was like demyelinating, but now some people they are putting it as a disseminated. Definition wise, ADM is a neurological disorder characterized by brief but widespread attack of inflammation in the brain spinal cord that damages myelin. The incidence, although it is a rare illness, estimation is 0.07 to 0.9 per 1 lakh children affected by ADM each year. But I think with MRI, we are able to understand it better. Age group, although ADM can appear at any age, children are more likely to get affected than adults. 80% of cases occur between 10 to, I think 80% of the cases occur before 10 years. I think there is some misprint, and 20% cases between 10 to 20 years. So most of the cases you will see before 10 years. There is some classification, I think, which is not in the scope of a primary care pediatrician, like monophasic ADEM and multiphasic ADEM, acute hemorrhagic leukoencephalitis, and ADM with optic neuritis. So I think this is not in the scope of a primary care pediatrician, but just to mention. Can we go with the next slide? Yeah. The etiology is mostly a viral infection: mumps, measles, rubella, varicella, influenza, enteroviruses. Post-vaccination, less than 5% cases of ADM will be because of vaccines. They are associated with rabies, hepatitis B, influenza, DPT, MMR, pneumococcal, polio, varicella. Do you, if we remember, there was a huge like a case front page like after taking a corona vaccine, the patient develops some neurological symptom, and then the vaccine is having so much complication. I think that was the post vaccination ADM. It was not the like side effect, but it was like one of the problems with corona vaccine, and that was actually ADM. The pathogenesis is like there has to be a genetic susceptibility, a environmental trigger factor, mostly a viral infection, and then there is a immune dysregulation by helper T cell and cytotoxic T cells. Eventually, the antibodies, cytokines, and chemokines, which are released, they make a neuronal damage. Symptoms are like confusion, drowsiness, coma, numbness, seizure, trouble in swallowing, trouble with vision, unsteady walk, weakness in arms or leg. Like if you see, like in CNS, there are like gray matter, white matter, cerebellum, cranial nerves. Like if you see a mixture of all getting involved, so I think it eventually turns out to be ADM. Like if you see only seizures and no white matter lesion, or if you see only white matter lesion, or if you see only like cerebellum getting affected, then the diagnosis can be different. But if we see multiple signs, CNS signs and symptoms, then mostly it turns out to be ADM. The differential diagnosis, like you should always think of a multiple sclerosis if the child is more than 10 years and if he's coming back to you with the scattered symptoms of CNS. Definitely, MRI is the cornerstone for the diagnosis. Multiple hypertense lesions you will see in T2 weight images. Even one lesion is enough for the diagnosis of ADM. The treatment is like gold standard is steroids, methylprednisolone. Kids, they respond wonderfully to methylprednisolone. If not, then you have to go ahead with IVIG, and in rare cases, you have to go ahead with plasmapheresis. Outcome is most of the time it is complete or near complete. Very few will have like persistence of symptoms like weakness, blurred vision, numbness, and incoordination. So it is a rare disease, simple disease to diagnose and easy to treat, but definitely you require support of a radiologist and a pediatric neurologist. And if done properly, then ADM can be treated at a primary care pediatrician. Like few years back, all cases I referred to Vadia because there was no pediatric neurologist to opine. But now Dr. Amit Watkar is there and is always approachable and very helpful. So all these things can be managed at our level with his guidance. So I am thankful to Dr. Amit Watkar who helped us to manage this case, because going to Mumbai and getting admitted in Vadia and getting through that all process is not easy. So I am really happy that such cases can be managed at our own places without sending patient to higher centers. So with that, I will like to end my short case history. And then I like Dr. Amit Watkar to share his experience, because I'm having little experience with ADM. I think now we like to hear Dr. Amit Watkar.
Yeah, so what I would like to say is that most of the time, if someone has a viral, we never know how the body will respond. So 90% of time, whatever the body does is that it removes the viruses and the body recovers. But sometimes there is some abnormal response, which can be even para or post-infectious. So we have to remember, it is not always that the autoimmune is post-infectious. Autoimmune can be also para-infectious. Means with the fever, we can get symptoms which present like an autoimmune disorder, or it may be few days after, like it can be up till 15 to 1 month, 15 days to 1 month after also, when we can have this abnormal response. Now the specificity of this abnormal response means it is diffuse. As it says that acute disseminated means you can have patchy involvement of the brain and you can have patchy complaints. Now, which complaints are very obvious? So, for example, if someone is looking at something and is not able to look, so that's a very obvious complaint. So, loss of vision. So, if there is a focal decrease in the movement of hand, but usually why movement of hand is most of the time related, or movement of leg, unless it is quite focal, it's not related to direct to some disease like in stroke, where internal capsule is blocked. There you will get a very focal hand disturbance. But if the same stroke is at the level of cortex, the involvement would not be that severe, because the cortical representation, a hand to get involved, is a large area. In edema, it is usually patchy and small patches. So you don't get very obvious symptoms like movement of hand or movement of leg or stroke-like features, but small things such as loss of vision in a single eye. If the child is not able to look to one side, if there is diplopia, so vision has patchy involvement because there are different nerves. So fourth nerve will present differently, third nerve will present differently, second nerve will present differently. Again, cerebellum. So cerebellum has a very peculiar feature that it acts in very important step in gait. So once gait starts affected, because walking is a very important part of our life. So once your walking start affected, everyone starts thinking maybe this is something different. But if a child is sick, lying on the bed, not able to move the hand, then sometimes they sick, well, he's too tired for not able to move the body. But walking, whenever it is affected and there are some vision, so both are two different things. So this patchy involvement should always give a rise to a suspicion that this is something demyelinating. Now, with treatment for demyelination is very quite standard. Either you stop the production of those antibodies who are causing this, or you don't allow them to bind to their desired place and let the body recover on its own. So in minor cases, usually this is self-limited, body recovers on its own. But in major cases, methylpred has very good recovery, almost to the tune of 90 to 95%. So I have seen children who are almost blind. So they are not able to see completely, and by the day fourth, they are able to see very well. And 3 days methylpred I have not found that helpful. I have always found that a 5 days methylpred to be quite helpful, and the remaining some maybe 10 to 20% of recovery when you extend methylpred with corticosteroids for a period of 15 days to month. I found them to be more helpful than just giving methylpred for 5 days. And in post-COVID area, there was a dilemma that it also presented like GBS. So in GBS, where there is the involvement is at the axonal level or at a demyelinating peripheral nervous system level, root level, this at that time, IVIG is the drug of choice. While when it is related to myelin, that is either to the myelitis, means when it is related to the spinal cord or brain, methylpred plays a better role than IVIG. If the patient does not improve with methylpred or IVIG, that too why we say IVIG, because IVIG is easy to administer, has less complications than plasmapheresis. But in post-COVID era, I had seldom found that just giving IVIG doesn't help. So we had to give plasmapheresis, because whatever the pooled plasma was there, that is most of the time from the pre-COVID era. So we had to go for plasmapheresis, which showed remarkable improvement in few of the cases who did not respond to IVIG. And most important thing is that if you keep on maintaining the child, if the child's vitals don't stop, if the nursing care is good enough, almost all of them respond good. So this is what I would like to say.
Sir, what is the severest form of ADM? Where the most severe form of ADM? Like, do they present with coma and then?
I have not seen that severe where they presented with coma. But then what happens that sometimes it recovers and then it again relapses. So when this is there, you have to think of other things such as whether there is multiple sclerosis that is setting in, or there are other things like MOGS or NMO, which are relapsing and remitting in the future. In this case, you have to maintain them on a long-term steroid cover and then subsequently add other immunomodulators.
Okay.
So
Especially
was
when it is a
MRI,
vision
so was
involved.
MRI done in this child? MRI
Yes,
done? MRI brain?
MRI was done, but for my eyes it was like normal. So I don't know like how
So
radiologists.
whenever you see a MRI, you are in this, the involvement is usually at the gray white matter junction, and mostly you can see those dark white patches on FLAIR images in the cerebellum or at those gray white matter junction. Very diffuse. You can see white matter one side, white shadow on the other side. So this usually gives the classical diagnosis of ADM.
So
And
if the
CSF
brain
can be
is so much
normal.
involved, then why was the consciousness not so affected and convulsions were not the presenting history in
Because
this
when it is
cases?
involved at a cortical level, a
Huh.
cortex, so the consciousness decreases when the involvement is measured at the brainstem level. So where the consciousness wires, that reticular tract, all those signals go up and down. Now, if that reticular system is involved, then the consciousness is involved. But when it is diffuse at the cortical level, the net representation on the body is quite limited. So you do not get impairment of consciousness in all the cases. Only when it involves brainstem or it involves significant tracts, just like means or major part of thalamus, then only the consciousness is involved. Like in case of leukoencephalopathies, where there is a hemorrhagic in basal ganglia. So basal ganglia, lots of tracts move from there to the internal capsule. So whenever there is that changes in the basal ganglia or thalamus, you get involvement of consciousness. But whenever it is at the cortical, subcortical level, now the net representation on the body is quite small representation. So you don't get impairment of consciousness in those cases.
Dr. Amit, the presentation of this case is very, very similar to like a Guillain-Barré syndrome. I mean, very almost near like post-viral, the symptoms and all
Both
that.
of these diseases are brothers. In
Acha.
Guillain-Barré syndrome, the attack
Yeah.
is at the level of roots. So you get more of a lower motor neurons type of lesions or
Okay.
signs and symptoms. In this, the attack is at the level of white matter and gray matter junction. So you get some amount of upper motor neuron type of lesions, and then because of some peripheral nervous system involvement, also you can get a mixed picture. But consciousness is not involved, and the pattern is not established. So here there is diffuse patchy.
Sir, are you
Okay, sir.
seeing
Thank you.
case of multiple sclerosis in your practice in pediatrics?
Multiple sclerosis, the pathology for multiple sclerosis is basically not because of a post-viral or something. In that, it is basically the body's immune system is failing or faulty immune system that causes recurrent demyelinating events. So single event, first event of ADM, usually not a multiple sclerosis, but when you find that presented as ADM, but subsequently just not going off, or it's not recovering completely, and there is always some mark getting left, which each and every episode, and the involvement is more in the white matter than mixed involvement, then you can suspect it to be a multiple sclerosis. But multiple sclerosis never at the first shot. It's as you follow up, you get to know what it is.
So my last question, can you enumerate some immunomodulators because we don't know anything about it. So can you name some?
Well, that's what I'm saying. Most commonly what works for our ADMs and GBS is these two major things, that is methylpiride and IVIG. So these two are like, means they are the, what we say, lift. So if you manage a person properly with good nursing care, he's going to recover at some point of time. But if you want to lift, fast forward shortcut, so these two drugs are the most common drugs that help in almost all the cases.
Okay.
But if they fail, plasmapheresis should be the second best option.
Okay.
Just because you have kept it second best, because the complications associated with plasmapheresis and the procedural difficulties, we cannot keep that first. And the easiness of administration, the easiness of monitoring the side effects is very good with methylpred and IVIG.
Okay, any
Sir,
danger
what
sign with ADEM? Like we have to be very cautious. Like suppose I am a primary care pediatrician with the guidance of a pediatric neurology. I am treating a case of a ADEM. So is there any dangerous sign on MRI or clinically that I should refer to a higher center?
Well, if there is a setting in of necrosis, if there is a necrosis, whichever comes either in the basal ganglia region or in the thalamus region, then you have to be careful because these cases can deteriorate rapidly. These cases can bleed internally rapidly. And sometimes some diseases like mitochondrial or other diseases can be a differential diagnosis in this case and very poor response to treatment.
Okay, so moral of the story, if MRI shows some necrosis in the basal ganglia, then better we refer to a higher center.
Means we have to think twice before labeling it just as a ADM.
Okay, sir.
Sir, role of MRI, orbit and spine in each and every case of Adam.
Now,
And
by and large,
the second
wherever there is an optic involvement, so optic involvement, a very different thing is that there is something called as neuromyelitis optica, which presents exactly like ADM. But in this, along with the optic tract involvement, you have a large cord spine involvement also. So whenever you have this optic involvement, you should get a spine MRI also done because this is a relapse in remitting case. In this, you can never find that once we are off the steroid, everything is fine. Most of the time, these cases tend to relapse. And unless we are aware that he may relapse, we would abruptly stop or we may stop the steroid so soon. Sometimes these cases require steroids even for a year or so, and then subsequently we replace them with azathioprine or MMF to continue the immunosuppression for a longer period of time.
So any case presenting first time with Adam, it is advisable to do a screening spine and orbit.
Yeah, screening spine is advised.
And second thing is roll of MOG antibodies. Roll of MOG antibody positivity in case of Adam cases.
So MOG is recently, means it's a well-known entity that has been established, but in MOG, the lesions what you get are usually quite larger than routine ADM. In ADM, the area is quite specified, but in MOG, you get most of the white matter involvement and the spinal cord involvement. In this case, you have to do MOG because just like NMO, even MOG requires a long-term immunosuppression cover.
So what is the full form MOG? So please tell.
This
myelin
oligodendrocyte antibody.
Dr. Amit, the MRI initially does not show any signs of ADM. The child clinically deteriorates. So how frequently an MRI should be done in case of ADM?
Well,
it's a progressive disease, right? It's a progressive disease. It can progress fast, it can progress slowly. So at what juncture of time the MRI should be repeated if the initial MRI does not show any signs of ADM?
I think, but this is just an arbitrary answer. 5 days should be good enough.
5 days. But before that, if the child progress is very fast and the initial MRI does not show any evidence of ADM.
If we are sure that it's a patchy involvement and the CSF doesn't show meningitis, because even meningitis, some cells would start coming, but in ADM, the cell response is not that high. So if you're sure of this thing, then we can start on steroids and see for the response.
If you have started with methylprednisolone, you have given IVIG, you have started with methylprednisolone, the child still deteriorates, then would you consider ADM and repeat the MRI? Would you change your diagnosis, or we will just wait and watch for the response yet to come?
If the child deteriorates, MRI should be done because it may not be just ADM. It may be something else that is coming up. It may be that meningitis is progressing. So there are lots of differential diagnoses that come into my mind if they are not responding to the methylpred. In this case, I would definitely, in fact, MRI with contrast to see whether there is some enhancement rising somewhere or whether there is something new thing that is cropping up.
So in
Dr. Amit, there
you
is a
say
high
that
probability that child can land up with a ventilator also, right? Very high probability.
So as the area gets involving, there can be further complications seen. So once if that
So
reticular
my
system part,
question is that can we manage on I mean peripheral level these cases, because if they deteriorate fast, then to shift also will become a very big issue if they deteriorate to uh, requiring
but
ventilator support or
if we
something like that.
diagnose it early, methylpred gives a good response. So within 3 days to 4 days, methylpred almost gets 70 to 80% of the recovery. And if we diagnose it early, most of my cases have recovered. And if those who are not recovered, then in that cases, it's probably not edema and the involvement would have been quite high and it could be something else. But by and large, if the MRI shows the, edema shows the classical picture on MRI, a diffuse patchy involvement. So by and large, if the MRI shows me though that sort of involvement without any necrosis, I'm quite confident that the child can be managed.
Sir, in your experience, like which is the virus which gives more severe involvement, like mumps, measles, rubella, varicella?
No,
Is
sir.
there
I
any
did not
correlation?
find anything such
Or there is no
variations.
correlation between the virus and the
No, sir. I
symptom
did not
severity.
find any of such thing.
Okay. Okay. At by your experience, what was the like youngest to get affected ADM? Like 6 months, 2 years, 5 years? Like your
Uh,
experience.
I found in a 1.5-year-old child who had loss of vision.
Okay, but was it a ADM or it is neuromyelitis optica?
No, the child did not recur and it was just ADM sort of thing.
Okay, so 1.5 year like was the youngest one.
Yeah.
Do you feel the ADM cases you are seeing more like I have seen these like in these 5 6 years I have seen. Before that I was not unaware. So it is that our awareness has increased or the incidence is the same for ages.
What I would like to say is that, well, the whole spectrum of autoimmune thing means either it is a GBS or a ADM or NMO. So these things were there. But as we are doing more and more MRIs and more quickly the MRIs and we are holding those steroids from the patients, we are able to diagnose it better. Otherwise, most of the time, if suppose I would have done a CT scan in this child, for some reasons, I would have done a CT scan in this child and there would have been some enhancement. I would have thought it to be viral encephalitis and I would have treated it on that lines. And maybe I would have given few days of steroids also, Dexa, which would have caused some improvement in this kid and the remaining would have been done by the body itself. So this case would have not been labeled as a
Viral.
edema and he would have been a viral encephalitis which recovered on treatment.
Sir, what is your take on methylpred versus Dexa?
Well, what I feel that whenever there is an involvement of white matter and especially demyelinating, you need to hit strong.
Okay.
And methylpred, that pulse goes and hits very well in my experience.
Okay. And sir, you mentioned about like after giving methylpred, we have to watch for a BP and sugar. So what is the reason behind it?
Because methylpred we are giving at a very high dose. It's almost 30 milligram per kg. So sometimes I have found this 30 milligram per kg of methylpred to cause hyperglycemia in 2 to 3 hours. It's not that it cannot be managed, but if you know that it is there, then we can manage it with the help of, sometimes these kids also require an insulin drip to get that high sugar level in control.
Okay. I think I have exhausted all my questions.
Related to most common virus related to ADM. So in my institute, there are more cases we are seeing about ADM. So in all such cases, most common symptoms was history of previous URTI 1 to 2 weeks back. In that case, when we sent this biofire assay, the most common virus associated with was this adenovirus. And other thing is that after COVID, we have seen around 8 to 10 cases who are COVID IgM positive and getting features of adeno.
So COVID is a part of our natural viral ecosystem now. So you should always suspect that if someone even has a cough and cold, he may have, there are 20% chances that he may be still be COVID. But only thing, our body is now equipped to fight COVID, we fight it. And of course, just like with any other virus, if there are 10 to 20% of COVID, there are other viruses who occupy the remaining 80% of the chunk. So yes, COVID is quite often, but in COVID, we have to remember that if the child requires IVIG or if there is an GBS-like presentation, there are chances that it may not respond to the IVIG as other cases respond.
Sir, can I ask one more question?
Yeah.
Okay, if there is a case of a cerebellitis, like still you will go with IVIG or methylpred, post-viral
Well,
cerebellitis.
as I said, whenever it is lower motor neuron, whenever it is the involvement of nerves, all those things, IVIG acts quite well. But whenever there is a central nervous system involvement, like the spinal cord or the brain, methylpred acts very well.
Okay.
Can Ankit Gupta sir give us some idea about acute management of ADM?
ADM, so few things that sir has told is I would concentrate on is the like how do you refer and the clinical severity. Many a times they present with this refractory status epilepticus, and Dr. Wasim had asked, can they go on ventilator also? Yeah, so they can go on ventilator, and you can have features of raised ICP. Sir has already told the treatment like methylprednisolone works wonderful with ADAM. And the earlier you do, if somebody is jumping, what we are seeing, we are jumping very early on day one and we are getting the MRI done. So many a times you will not get symptoms on day one itself, or you are maybe you may miss that, So don't, I would say, if there are not much symptoms, then don't jump on day one or day two and don't get an MR done on day one or day two. Okay. So maybe from day three, if Dr. Watkar can say, from day three or day four, the images, the subcortical that these things are there, the shadows, they can become more prominent.
Yeah. The thing is that once the symptom starts coming, if you just have some non-specific symptom, then maybe you won't find anything. But if the symptoms are there, like there is a loss of vision or there is definite ataxia, in this case, without the central involvement, you won't get peripheral signs. So there has to be a central involvement to get peripheral signs. In these cases, most of the time, the MRI comes positive.
And as sir asked that, so these ADAM, the NMO, MOG, all these are all these post-viral mediated, autoimmune and the para-immune, as sir has told. So, and he has rightly told that COVID is a part of our ecosystem now. Initially, when these MISC was there, so we used to get a lot of patients who were coming to us with blindness. We used to give them methylprednisolone. Sometimes they required IVIG and they were doing fine. Okay. Just you have to keep monitoring that they should not recur again and again.
Dr. Ankit, can both be given, methylprednisolone and IVIG simultaneously?
No, if you're getting good response with methylprednisolone, then why do you want to give your, IVIG?
No, depending on severity, can we give both of them? That's what I want to know.
If it is very severe, then I would give him. Okay, but if it is not, then just methylprednisolone should suffice. Huh?
For relapse, again we go with methylpred or prednisolone is good enough for relapse?
No, if there is relapse, so methylpred, as I said, if there is an involvement of tract, you cannot take a risk that because prednisolone may not act in most of the cases. But if there is an involvement of tract, you have to give an initial methylpred to decrease that inflammation quickly. And what both methylpred and IVIG act in a different way. So methylpred reduces the inflammation at the cellular level as well as it decreases the immune response from the body. But IVIG goes and binds to the immunoglobulins. So both of them act in a different way. So most of the time methylpred, if it is working, there is no need to give IVIG just because of thinking that maybe I will make the recovery fast. Because when the soldiers are only not there, whom is the IVIG going to go and bind to? So, by and large, methylpred works well. If no response, then one can go for IVIG.
For relapse, what is your take? Same
Relapse,
methyl.
you have to find why it relapsed. Because most of the ADMs don't relapse. So if it has relapsed, then you have to again look in detail whether it is some of the antibody mediated diseases, some of the inflammatory diseases that are going there. Is it either NMO or MOG or something else that is cropping out, which you have to pay more attention rather than treating. Methylpred always cures. Any form of relapse, methylpred, if it has helped first time, second time also it will help. But just getting out of the episode should not be the target. Preventing the second relapse should be, third relapse should be the more priority than stopping this attack.
I think Akash Patil he has seen many cases.
Yes, sir. Because I was at Science, so Science was a reference center for neurology. So there, in such cases, we first rule out the any antibody if there are certain antibodies positive or not. If the antibody is not positive, then we labeled it as an autoinflammatory syndrome instead of autoimmune disorders, and straight away go with IV methylprednisolone. But if it is antibody positive, then we screen the spine and MRI orbit and rule out the NMO and all these things. So in such cases, our first line of management will start with IVIG, and depending on the response, we'll start them on maintenance dose prednisolone, and over the period of time, 6 to 8 weeks, depending on the response, will in a case of nephrotic syndrome, the dose of prednisolone we taper over a period of time. That type will start them on prednisolone dose.
Okay, next time if Dr. Amit Watkar is not available, I will contact Dr. Akash Patil.
No, sir. I am general pediatrician only, sir. I have not experienced like sir. So I'm just giving my experience data, sir.
Yes. But like what you are doing, Adam, I am always thinking of that Adam Gilchrist. Now everybody's like, at our time it was ADEM. Now new generation is talking Adam. So next thing which comes in my mind is Adam Gilchrist.
Hello.
Bola
Yeah,
sir.
Akash is available every evening, 5 p.m. to 8 p.m. at in Virar. So let's get benefit. Thank you.
Great. Excellent.
Anjali ma'am, you are ready with your slides, ma'am?
Yeah. Excellent talk. Dr. Amit, please don't leave, because even my case has a neurological complication. And Ankit,
there.
yeah, please. Yeah, so I'd like to present my case. Yeah, is it visible now?
Yes, ma'am. Yes, ma'am.
It's visible, Anjali.
Yeah, so we too had a case early this month. This was a 9-year-old child, 2 days history of swelling in the cheek, 2 days history of fever, cough and cold, vomiting and headache since 1 day, and poor intake was very dull for the last 12 hours before admission. This child was vaccinated with doses of MR at Municipal Hospital, and he was detected with transfusion-dependent thalassemia some time back and was at regular treatment at CTC. He was very dull, dehydrated, he was pale, he had swelling over both his parotid glands, which were tender, no meningeal signs, and liver 5 centimeters tender. his spleen was 3 centimeters non-tender, and he had vague tenderness over the epigastrium where his left lobe of the liver was also palpable. His investigation, his hemoglobin on admission was 8.5, WBC was 7,000, platelets were normal, his serum amylase was 4,000, and his LFTs were normal. So the course involved, he had nausea, vomiting, which was persistent for 2 days and was slowly improving over the 3rd and 4th day. Headache and lethargy also lasted for 2 to 3 days. On 2nd day, because his headache was not improving, we took opinion of Dr. Ankit Gupta, as we were wondering whether we needed to give him hypertonic saline for his headache and increase ICT. Unlike Dr. Nilesh's case, our patient had no focal deficits, had no seizures, and had no ophthalmic this as well. So it was a non-specific signs of headache and vomiting. And Ankit, would you like to say something over here?
Yeah. So when I saw this patient, so he was not having any focal neuro deficit. The only vague symptom was he was having headache. And if you go through the history and some treatment, so he had become slightly dehydrated. Okay. So just my thing was, because there is no focal neuro deficit, I'm not suspecting raised ICP in him. So if you just hydrate him, he would become better. My one concern was, because he is a thal and he has become dehydrated, so he can have some intracranial thrombosis. Okay, that was what I was thinking that time.
Yeah.
Otherwise, he was comprehending everything. He was talking, okay, everything was fine. No, as such, he was not a very sick-looking guy. At the most, if he has headache, he could be, if it is because of mumps, he could be having some mild this aseptic meningitis, for which the treatment is very supportive. You don't need to give him anti-edema measures. And because it was thal, so I did not want to load him with any more concentrated hypertonic saline or mannitol or stuff like that.
It was such wise advice, because on that very day, he was actually due for his transfusion. It was 21 days past his day of transfusion, and so we had transfused him. And Dr. Ankit was of the opinion that this was because of the transfusion, and perhaps there was hemoconcentration and dehydration worsened the whole thing. And that's what we did. We just continued with IV fluids, and we gave him analgesics. And by the 3rd day, so this was on 2nd day, 1st day he came with swelling in the neck and in the cheeks and high fever, headache, vomiting. By 2nd day, he was taking liquids. And by 3rd day, he was much better. We were wondering whether we needed to do an MRI to rule out any, thrombotic events, or whether there was a hemorrhage also, which was complicating this whole thing. But this child had undergone several tests for his thalassemia, and MRI was also, I'm sorry, there's a spelling mistake. MRI was also done 6 months ago for other reasons and not for the same illness. So we deferred that treatment and that investigative modality. And we had consulted Dr. Ankit the night before. By next morning, he was much better. Just hydration had done the trick. And he slowly improved. And by day 6, he was sitting up and having fluids and food also. Mild nausea and headache were present. And by day 4, he was having semi-solid, and he was discharged on day 5. So mumps, we know, is a paramyxoviral RNA. It has several genotypes. Now, I had 1 or 2 patients who had taken MRI with me and got mumps, So I was wondering, I said, how did this happen? Was it, vaccine failure? But it is known because although there is just a single serotype, there are several genotypes. And any of the genotypes can cause a repeat infection. And the repeat infection is much milder than than in unimmunized children. Humans are the only host, and right now it is in epidemic proportions. The virus targets salivary glands, the testes, to less extent ovaries in adolescent children, both of this, the thyroid, heart, kidney, liver, joints, and of course the brain. Symptoms and signs The incubation period is pretty long. It's 12 to 25 days. Why is it important to know this? Because one child was in contact with his sibling who had mumps, and she came to me within 2 to 3 days, and I did give the mumps vaccine, and 20 days later the child developed mumps anyways. So the incubation period is quite long, and we will never know if this child was infected. And the infective period is from 5 days before the appearance of parotitis to 5 days after the appearance. The prodrome is for 1 to 2 days with fever, headache, vomiting, and parotitis follows initially unilateral and then bilateral. There is ear pain initially. So very often I have seen a child with ear pain, thought it is otitis media, and then few days later there is a cheek swelling. Sour and acidic food increase salivary gland pain. Swelling peaks in 3 days and settle over 7 days. Submandibular glands may also be involved. I had a child who had the submental, submandibular, and a parotid gland involved. So that can be and the whole thing looks so huge. The complications are meningitis, meningoencephalitis, edema, transverse myelitis, aqueductal stenosis. We know that children born with congenital hydrocephalus can have aqueductal stenosis if the mother has suffered from mumps. This can also happen secondarily, and perhaps Dr. Vatkar will clarify this. They can have facial palsy. They can have sensory neural hearing loss. So any of the ADEM patients, or even those who had meningoencephalitis, should have their hearing tested. They can have orchitis and oophorytis, especially in adolescent children. Pancreatitis is known, cardiac involvement is known, arthritis for some reason is known, and thyroiditis. The prevention is only with one dose at 15 months, followed by a second dose at 4 to 5 years. Now, this was one of the cases which has been reported. This is a perspective which has come in the e-version of this month's Indian Pediatrics. There is a recent surge in mumps cases in India, and there's a need for urgent remedial measures. Now, this people have been shouting this from the top of their voices and the top of their roofs. But I hope that the government does take some action. We conclude that in this abstract that the inclusion of mumps component as MMR vaccine in the Universal Immunization Program of India, along with strengthening surveillance, is required to tackle the situation. There was an app by Indian Pediatrics which was called the ID Serve. That is the infectious disease surveillance. But I don't know, some years ago it was very active, started in Gujarat, but of late I don't know of its activity, and I think we should look that up. So this was about the mumps. So in conclusion, I just want to say that mumps is at an epidemic right now. CNS complications are uncommon but distressing. Not so uncommon in our presentation today, because there are 2 out of the 4 cases which were mumps complications. And MMR vaccine can prevent this disease and its complications. Ankit, we'd like your input as to how many cases you all see with CNS complications presenting to you all at Wokhad.
So we are having, like, currently 2 cases are there. Regularly we are getting since this epidemic has started. So basically they are this meningitis, meningoencephalitis. And it can occur anytime. Maybe it can occur up to a month also after your mumps. Sometimes it can be preceding your this parotitis also. Okay. And so you have to suspect that, especially when this epidemic is ongoing. And the other thing, whenever you are doing a LP, so generally when you viral meningitis, we are not used to seeing very high cells, 200, 250, 300. So in mumps, the CSF picture is known to mimic bacterial meningitis. Okay. That is what you have to remember. And you will get this, the sugars are sometimes low. So you should not get, this could be a bacterial infection. So still mumps should be a DD, especially in these times. Most of them, they improve. Okay, they present with they have severe headache and they become encephalopathic. They keep shouting. They're very irritable. Okay, neck stiffness is there. Okay, so if you are examining your child properly, you will get neck stiffness. Okay, so of these years of my decades of experience, only now I'm getting neck stiffness. Okay, that was just a joke. So only now I'm getting neck stiffness. Hardly I used to get neck stiffness before. So now with these mumps, I am getting neck stiffness, and most of them are improving very well. Okay.
Yeah, Dr. Amit, you have something to add?
Well, as I said, these mumps, because we have started this MR vaccine now, so what viruses tend to do that whenever someone starts declining, the other virus starts to predominate itself. It starts taking the place. So with the advent of good vaccination systems, we are getting that most of the viruses routine which we used to find are getting less and less, but the new viruses which were initially in lesser amount are getting more. After this COVID, because there was a huge gap in MMR vaccination, even measles and mumps both have started cropping up their heads. And this mumps is specifically notorious for the otitis, orchitis, and meningitis. So these three things. So whenever we with mumps, rather than thinking of EDM as the first thing that would have affected, we should always keep in mind probably it is the meningitis that is there, and this meningitis means EDM recovers very good, but this meningitis with mumps can lead to worse things if not treated in time. Unfortunately, we don't have a medication to treat these mumps, but supportive treatment should help well. And if this deafness sets in, only thing we can do is monitor for the deafness, and deafness doesn't come, rather than doing something more proactively. So this is what I would say. And yes, mumps is definitely on rise. So the only solution is that we should go for vaccination, and we should advise everyone to take vaccination whenever provided a chance.
One point I want to add rather than a query. Many times nowadays we see tonsillitis with submandibular swelling, a pustular tonsillitis thing with submandibular swelling, like bull's neck, and also mumps can cause such type of thing. Both of them can be together, we have seen now. But only thing which differentiate is that if we do serum lipase and amylase, almost 99% of the mumps have positive, some or the other, little bit also raised of amylase and lipase. So that investigation can differentiate from other differential, like madam you said ki ear pain can later on comes as mumps. So if you do amylase lipase in early phase, you can definitely diagnose mumps in a better way.
Yeah, well said. Even our patient had raised serum amylase.
So almost all of them has serum amylase, which is raised. Yeah.
Dr. Hemant,
just one doubt.
Yeah.
Just one doubt. Is a thalassemia is a hypercoagulous state like sickle cell anemia?
You mean thalassemia have a hypercoagulable state? Yes.
Yes, okay. Because in sickle cell, there is some RBC membrane defects and all. Because of that, there is a sickling, and that's why there is hypercoagulability. But in case of thalassemia,
even thalassemics are prone to thrombotic events.
Okay, sure.
Yeah, Dr. Hemant Joshi, you are out cycling on a 7-day cycling trip. You'd like to say something? You have to unmute yourself, Hemant.
Yeah, no, I want to say something else. See, IAP has been recommending to Government of India since long to give MMR in place of MR. But Bhagat Singh put a bomb because government doesn't listen to small voices. So we all 40 people should write a mail to the Prime Minister. I'm writing that draft and putting it in the text. We 40 emails should go today. So let him receive at least 40 emails today. And if possible, you write a letter, postcard or one handwritten letter on your letterhead and send it that IAP has recommended you don't do it. Listen to Indian pediatricians.
Okay.
If the office gets 40 letters, they'll do it.
Okay.
At least we will not be guilty of not doing anything. So let's do that. Thank you.
Thank you. Now we have just 10 minutes and I'd like to take up the topic of epidemiology, and if anybody has some very classic cases seen in multiple, in very large frequency, please do let us know. What about you, Sailesh? Yeah, Hemant.
We have seen 2 cases of mumps with chickenpox both together.
Two
It is single
cases
shot.
of
Mumps and chickenpox in a single patient.
both
Together.
Unusual.
I think chickenpox is coming up quite freak. I've seen a lot of 3-4 cases myself of chickenpox.
Mumps and chickenpox together.
Oh my God, 2 viruses.
Yeah.
So, and both are vaccine preventable illnesses.
And if the clinics are coming multi-speciality, so viruses are also coming together now.
Multivirus.
So, they are also following doctors, multi-speciality hospitals. So viruses are also coming together now.
Yeah. I saw 2 cases of streptococcal sore. I don't know whether that's coming up one child I saw today which looked like scarlet fever. He had a strawberry tongue, a very severe sore throat, and a palpable rash over his body. So like scarlet fever, and 2 such patients. So I don't know whether we are also getting bacterial sore throat. So
I think it's marriage season now, ma'am. I think most of them are having a lot of cold drinks and ice creams. I think probably that's why the cases are rising.
Meeting a lot of other children and getting infected.
Yeah, getting
lot
infected.
of aseptic meningitis, viral meningitis, they are coming to us. Okay.
Have you
saw two culture positive enteric fever treated with ceftriaxone.
Okay.
Epstein-Barr viruses last week.
You saw Epstein-Barr virus. Dr. Ankit, I wanted to ask you if you have isolated any virus by your PCR multiplex test on CSF, and whether mumps PCR was done in any of the cases.
Yes, gone.
Yeah. Yeah, I wanted to mention one very unusual and very painful case. A small child, 4 years old, fell in the school and she had a tongue cut. The 1/3 of the anterior 1/3 was cut into 2. And when she opened her mouth, her one tongue was going this side and one bit was going that side. It was so painful. And we had to take stitches. I think I put it up in the group that an ENT surgeon did that. But it got badly infected. She went home after the stitches, but it was so painful for her and it was so bad that she came back severely dehydrated. We had to admit her, give her IV fluids, and it took at least 3 or 4 days for that tongue to recover. So I think that huge wound, still, it was a great thing that it recovered in 3 to 4 days. So if you get a severe tongue injury and it needs to be stitched up, then this child will do well by being hospitalized and given IV fluids, because it's difficult for that child to eat or even move the tongue. So this was one of the cases I saw. I think someone was saying something.
We saw 2 cases of enteric fever, typhoid fever, which were culture positive, treated with 10 days of ceftriaxone and responded well.
Great.
And I saw one case of viral pneumonia that was an 8-year male child with bilateral pneumonia, mid-zone, lower zone. His count was normal, 9,000. So along with antibiotic, we gave him Fluvid and he responded within 72 hours of Fluvid. Yeah. And X-ray, in X-ray, there was no much of an improvement, but fever reduced and clinically child became better. So we discharged the child after 5 days of antibiotics and Fluvid.
Very nice.
At Joshi Hospital, ma'am, we have in last 10 days, we have seen 6 patients of UTI positive sepsis. I don't know it is lab contamination or what, but all patients were E. coli. UTI sepsis, ma'am.
E. coli
U-
sepsis.
E. coli
UTI.
sepsis. UTI, urine culture positive with E. coli.
Hey, what
Okay,
was
okay.
the age group? Age group?
Yes, sir. From all cases, sir. From I think 2 years was minimum age, and I think 12 years one nephrotic syndrome case also having E. coli UTI positive, and the E. coli was pan resistant to all of the routine and even third generation cephalosporin fluoroquinolones, only sensitive to the colistin and tigecycline. So I don't know it is lab contamination or it is just a E. coli UTI
I
outbreak
don't
or
think
what.
so.
Akash, that
I
is
don't think so. I
Akash.
don't think so. Community acquired will be so severe with multi-drug resistant type. It must be a lab error, I
Maybe
guess
so.
so.
Maybe lab error, I think.
Akash, we see this type of report every time. We see
Yeah.
for whether clinically the child is responding or not, because most of the time it is orally or oral cefixime also suffice to treat them. So we usually ignore such report if the child is clinically well.
Okay, sir. And one case of paratypic culture positive, sir, which is sensitive to azithromycin and cefixime. He is responding well. And the third case with bilateral pneumonia without any need of invasive ventilation. And after 7 days of antibiotics, he was positive with Acinetobacter baumannii, which is showing intermediate sensitivity to colistin and sensitivity to the
Okay,
tigecycline.
Acinetobacter
But how we
baumannii.
got Acinetobacter?
But you are talking blood culture or what culture you are talking?
No, sir, it's a sputum culture, not blood culture.
Yeah, contamination.
Okay.
It is contamination.
Maybe.
But
Very
sir, in
unlikely.
such case, even if it is a contamination and if the child is not responding to the 7 to 8 days of third generation cephalosporin and this aminoglycosides, in such case, do we have to treat such patients with colistin if sputum culture is suggestive of Acinetobacter?
Sputum,
But Dr.
how you have
Akash,
collected that
are
is
you
more
sure?
important.
Sir, go on.
What, sir?
Sir, if you are facing a problem of bilateral pneumonia which is not responding to your usual antibiotic, and if the child is symptomatically bad, then you must go for bronchoscopy, take bal lavage and go for the culture rather than just treating with sputum specific for Acinetobacter.
If you read the literature, Acinetobacter is always a hospital acquired infection. Like
Absolutely.
Yes, sir.
yeah.
Yes, sir.
So unless and until the patient is intubated or you have done some intervention, it is very unlikely to get a child with Acinetobacter. So you have to take
And
with
it
a
can be with a bilateral pneumonia, it can be a viral picture also, which is not responding to your routine antibiotics. But the child
But
is
sir,
well.
viral pneumonia should improve within, I think within 1 week. He
Yeah,
was
but
not
Within
at least 1 week. She should improve with viral pneumonia, and
see, it is
he
not
is
good
daily
to put
getting.
then it is not good to put any time frame for virus. But as Dr. Shailesh Barut said, na, like if you are suspecting such thing, better you go with some bronchoalveolar lavage and get the things done. I think Dr. Mahesh Mohite's son is doing well in this specific area of invasive respiratory, and then we can take his help and take his advice. So I think everybody should take help of Dr. Mahesh Mohite's son. I don't know his first name. I think Chinmay or Chin. Yeah, and he's doing quite good work. So I think if we are having some, yeah, and I think we should take his help more and more.
ये दूसरे
Ahead.
ग्रुप में दोनों ग्रुप है ना मग दूसरे ग्रुप में जाओ ना हमें
Wasim, it's 5:30.
Yeah, yes, ma'am.
Madam,
So
pass on
thank
to
you.
us. Pass on to us. Caring is caring.
So I think all are very hypoglycemic now by the session, and but it was a very informative session, and excellent discussion was done. And I would like to thank all the speakers and all the people who have contributed for this event. Thank you so much, and I think we'll call it a day.
Special thanks to Dr. Amit Vadkar and to Dr. Ankit Gupta for being here.
Yeah. Thank you.
Thank you. I have
Thank you.
sent the Word document in the participant list on which I have tried to answer few questions in points as well as in details for whoever would like to refer.
Thank you so much, Amit.
Okay. Thank you, everybody.
We
Thank
should
you, everyone.
thank
Thank you.
Smita Chavan, madam. She is observer of today's CME. So special thanks
Thank you,
to
Smita ma'am.
Dr. Smita Chavan, ma'am.
And thank you, Anuradha, for always getting us CME points. And this time too, you have got us CME points. For the last 2 years, Anuradha has worked very, very hard to do that. Thank you so much.
Thank you, madam.
Thank you. Thank you. Bye, everyone.
Thank you. Bye bye. Thank you.
We meet on the 4th Wednesday of next month.
Okay. Thank you. Thank you all.
Thank you, Pallavi. Thank you, Pallavi, for being with us.